What is going on, everybody? Today we're going to be talking about back pain, and specifically we're going to be talking low back pain. And I want to give you guys pearls today on how to approach the patient who comes in with low back pain, because this is a very common complaint. And it's estimated that about 80% of people will have this complaint at least once in their lifetime. Now, the good news about a patient coming in with low back pain is that most of the time there's nothing to do. 90% of these patients are going to resolve on their own within 4 weeks. So today we're going to be talking about possible red flags. Do we need to order any lab testing? Do we need to do x-rays, MRI? What are the indications for these imaging studies? What are the indications to do testing? Are we worried about cancer? Are we worried about infection, abscess, osteomyelitis, for example? So we're going to be going over this patient here with the low back pain symptoms, and whether you're in the family practice, OB-GYN clinic, urgent care, emergency room, you're going to run across a patient. So let's quickly go over some clinical pearls on how to approach the patient with low back pain. Now, let's get some quick definitions in here, right? We're going to separate the low back pain into acute, subacute, and chronic. The acute back pain is going to be anything less than 4 weeks. Subacute is going to be anything between 4 and 12 weeks. And then finally, we have the chronic back pain patient. This is the patient who now has over 12 weeks of symptoms, right? 3 months. Like I said, the majority of patients will self-resolve. The majority of patients have something by the name mechanical back pain, which is just musculoskeletal back pain. There's not much to do. A little bit of anti-inflammatories, some rest, and physical therapy if need be, stretching, and they're good to go. Majority in 4 weeks. So let's get into some key terms that we need to be aware of, right? Now, if you've ever sent a patient for an x-ray, then I'm sure you've seen them, but maybe you're not 100% of what these mean. So we're going to go over some key terms that you need to know, and we're going to describe them very, very briefly. Now, the first term here is going to be spondylosis. This is simply going to be arthritis of the spine. Next, we have spondylolisthesis. This is when the vertebra slips forward onto the vertebra below it. Then we have spondylolysis. Now, spondylolysis is going to be a fracture in the pars interarticularis, which is also called the isthmus. This connects the facet joints. Spinal stenosis. This is narrowing of the spinal canal. And here we have some differentiators that we need to be aware of, right? We have spinal stenosis, and spinal stenosis can present with something called pseudoclaudication, also known as neurogenic claudication. And we need to be careful because we need to differentiate, does this patient have pseudoclaudication or do they have vascular claudication? So things to keep in mind, right? As far as the differences here. Pseudoclaudication, we do not have a vascular problem. Therefore, pedal pulses will be intact. Symptoms are just as prevalent standing as they are walking, right? Because if we have vascular claudication, we could think of this as angina in the legs, right? Peripheral arterial disease occurs when we have motion. Once we're exercising, we get leg pain. When we stop, it's relieved, right? Relieved by rest. Pseudoclaudication, you're going to have the pain whether they're standing. It doesn't matter if they're standing or if they're walking. And the maximal pain in pseudoclaudication is going to be felt mid-thigh, not the calf like we would in vascular claudication. So spinal stenosis has pseudoclaudication, aka neurogenic claudication. This is essentially going to be pain or weakness and or paresthesias that are going to be felt in the buttocks, thighs, and legs bilaterally. Now, spinal stenosis, we could see something by the term shopping cart sign. Shopping cart sign simply means that the pain is going to worsen with walking, but it's going to improve when they lean forward. And the reason it's called shopping cart sign is if you can picture a gentleman or a female holding and resting onto a shopping cart. When they do this, they're bending forward, and this is going to improve the pain. This is called shopping cart sign seen with spinal stenosis. All right, so now we're going to get into some possible etiologies here. Like we said, the majority of patients have something by the name mechanical back pain, or it's musculoskeletal pain. Now, the most common identifiable cause is going to be osteoarthritis, right? It's going to be degenerative changes of the spine. Now, the majority of patients don't have anything serious. They don't have cancer. They don't have infection. They don't have cauda equina syndrome, which is something you always worry about, especially as a student, and you think everybody that comes in with low back pain and a little bit of paresthesia has cauda equina. The majority of patients do not have anything serious. Therefore, the majority of patients do not require routine lab. They don't require routine x-rays or MRIs. Less than 1% of these patients are going to require imaging. They're going to require laboratory studies. So let's get into these exceptions right now. So there are really three major conditions that we want to look out for, right? Big time red flags. Cauda equina syndrome is a big one. Cancer is a big one. Spinal infection is a big one. Now, when we're talking about spinal infection, we're talking about abscess and or osteomyelitis. So spinal abscess, osteomyelitis, right? We have three big ones here that we need to worry about. We have cancer, we have cauda equina, and we have infection. These are the three things that we're going to be worrying about. Now, cauda equina is most commonly a result of a metastatic tumor. And it's going to be the initial presentation in about 20% of patients, right? Of cancer, sorry, I should say. So it's going to be the initial presentation of cancer in up to 20% of patients. Now, other things that can lead to cauda equina are going to be hematoma, abscess, and even disc herniation. Now, aside from the low back pain, you're also going to want to look out for weakness, numbness, which can also be seen as saddle anesthesia in certain textbooks, paresthesias, and we're going to have motor deficits that are not going to be localized to a single unilateral nerve root. Bowel and bladder dysfunction can also be seen. This is the incontinence part of this, but this is a late finding. Don't wait for bowel and bladder dysfunction to start thinking about cauda equina. Now, so that's cauda equina. So we have cauda equina, cancer, spinal infection. Now, moving on to cancer here, right? The bone is going to be the most common site of metastasis. So anybody with a history of cancer and a new onset of back pain, they deserve a workup for metastasis. They deserve a workup for pathological fracture. So remember, patient with established cancer presents with new onset back pain, they require a workup. These are not the people that we just want to sit back for 4 weeks, right? Metastasis occurs. Bone is the most common site of metastasis. We have to look low back pain, cancer, all right? So now the last one here is going to be infection. Infection, we're talking about spinal abscess and we're talking about osteomyelitis. So how do we differentiate this? Now, osteomyelitis and epidural abscess, right? So the epidural abscess is going to present with fever. For the most part, there's always exceptions to everything that I'm going to be discussing here, but patients with epidural abscess will present with fever. There should be a suspicion of an abscess in patients who are immunocompromised, injection drug users, and in those who have had a recent spinal injection or epidural catheter placement. Osteomyelitis isn't as intense. It presents as a gradual worsening of pain over a few days. Now, the patients may or not have any other symptoms, but the incidence of osteomyelitis does increase with age, and the most common etiology here is going to be Staphylococcus and E. coli. Now, if we have suspicion for any of these three big ticket items, like we're going to call them here, then immediate imaging has to be done. Immediate referrals have to be done. So let's quickly recap what we just discussed. The far majority of patients will get better in 4 weeks. 90% of patients will get better in 4 weeks. Typically, the most common cause is going to be mechanical back pain, but the most identifiable cause, degenerative changes of the spine. If 4 weeks is considered acute back pain, we don't need to do any routine imaging. We don't need to do any type of laboratory workup unless we have suspicion for spinal infection, cancer, or cauda equina, and we discussed the possible signs and symptoms that are associated with each of these. So like we said, less than 1% of these patients are going to deserve a workup. So when you're doing a physical exam, when you're doing the ROS, you're really looking to rule out those conditions. It's a lot easier to rule these things out as it is to try and find an immediate cause. So focus your physical exam on excluding the three dangerous ticket items: infection, cancer, and cauda equina. Now, how do we do this, right? Well, we're going to look for some key questions, or we're going to ask some key questions. Location, duration, severity. We're going to ask about weight loss. Do they have night sweats? Do they have a history of cancer? Any trauma? Do we have any new medications, or have they taken any medications to help alleviate the pain? We're going to ask about neurological symptoms. We're going to ask about injection drug use. We have to ask about chronic corticosteroid use, right? These are all things that are going to help guide us in differentiating between the benign back pain and the dangerous back pain here, right? So we're going to get a good history. We're going to do a good physical exam. Now, after doing the history, like we said, then we're going to move on to the physical exam. But most of the time, the patient is going to present with non-specific back pain. This means the initial physical exam is used to assess the need for further imaging, not necessarily to uncover an etiology. Again, this is a very important point that I really want to drive home. You're doing the physical exam. You're asking these questions to see if they require any further workup. In other words, you're trying to exclude disease here. So when we do a physical exam, we're going to do 4 different things. We're going to look at the curvature of the back, right? Do they have scoliosis? Do they have hyperkyphosis? Next, we're going to push on the spine and we're going to look for tenderness. This can be seen in fractures, infection, metastasis, and a step off can be seen in spondylolisthesis. All right, step 3, we're going to be inspecting the hip. And tenderness over the greater trochanter is seen in trochanter bursitis, and oftentimes trochanter bursitis can be mistaken for lower back pain. And then finally, we're going to do a neurological exam. If radiculopathy is present, then we're going to focus on the L5-S1 nerve roots here, right? And remember, L5-S1, distribution of pain, sensation, weakness, and stretch reflex. These are the things we're going to look for. L5-S1. The L5-S1 nerve roots are going to cause pain that radiates to the buttocks, lateral posterior thigh, lateral posterior calf, the plantar foot, or the toe. Numbness, right? So now we're moving on to sensation. Numbness will be felt in the lateral posterior calf, plantar, dorsum of the foot, and or in the web space between the first and second toe. Moving on to weakness. So we did pain, sensation, moving on to weakness. Weakness is felt during hip abduction, extension, knee flexion, plantar flexion, toe extension, flexion, so toe extension or flexion, and foot inversion or eversion. And the stretch reflex is going to be lost in the Achilles tendon, right? In the Achilles tendon, so the ankle, we're going to lose the stretch reflex here. Now, the L4 nerve root, we're going to have loss of dorsiflexion of the foot, loss of sensation over the medial aspect of the foot, and we're going to have loss of knee reflexes. Now, moving on to step 5. So we did the neurological exam very quickly. Step 1 is to look at the curvature. Step 2 is to push on the spine. Step 3, we have to inspect the hip. We don't want to mistake low back pain for trochanter bursitis. Step 4 is to do a neurological exam. And step 5 is very simple, basic, just a leg raise. We've all learned this in school. This is a useful test to see if symptoms are radicular. Now, we have 2 types of leg raises here. We have the straight leg raise, and we have the contralateral leg raise. Now, for the straight leg raise, right, the patient is going to lie supine, so on their back, with their foot dorsiflexed. Next, we're going to raise the patient's leg on the side where symptoms are present, making sure that the patient does not assist in lifting, right? So make sure the patient is not helping you elevate their legs, make sure they're relaxed, and then you are the person that's doing the movement, the lifting. A positive sign here is going to be in the presence or worsening of radicular pain. It's not low back pain. It's not hamstring pain. This is a test to look for radiculopathy. It's only a positive sign if we have worsening of the radicular pain, or if we have the onset of new radicular pain. A positive sign is not low back pain, is not hamstring pain. If the radicular pain is unchanged, this is also a negative sign. All right, moving on to the contralateral leg raise. And honestly, this is the same thing. It's the same thing as the straight leg raise, except we're lifting the leg on the opposite side, right? Opposite of the symptomatic side. Now, this is going to have a higher specificity, but it's not as sensitive for disc herniation. All right, last step here is going to be step 6. And here we have to make sure that the back pain is not associated to any psychological cause. Now, a few things that are going to give this away, right? Very superficial tenderness, straight leg raise that improves while distracting the patient, non-dermatomal distribution of pain and sensory loss, inconsistency with other movements, like watching the patient get off the exam table completely fine, or maybe pain is elicited by pressing down on the person's head and or while rotating the body. These signs that we just discussed are called waddle signs, and multiple positive signs indicate a positive psychological problem. So it's not enough to just say they have one of these signs, i.e. they get off the bed. However, once they start to have more than one, multiple, we have to be careful. Now, sometimes they might think that they actually have back pain, even depression, anxiety. These are all things that can cause real physical pain. So we have to be cognizant of the fact as well. We cannot just dismiss them as faking. However, again, there are multiple reasons as to why somebody would have quote unquote psychological back pain. And we're using waddle signs here to look for multiple positives to guide the direction. So this is the physical exam here. Now let's move on to imaging and lab testing. Do we need any types of labs? And honestly, the answer is no. Now, the only exception I would probably say is maybe an ESR and a CRP. But even then, is it not necessary, right? Initially, you're not going to be looking for infection with an ESR. Initially, you're not going to be doing a CRP. How to look for infection. There's other ways to do it. Then you can use the ESR later down the road to maybe help guide therapy. However, the one big exception I would say is possible malignancy, aside from the infection here. But it's not going to be the first thing that we order, right? The ESR is not going to be the way we're going to differentiate. Remember, the ESR, the CRP, these are just labs that indicate inflammation. Very, very non-specific. So you can't really do all that much with it. So how do we figure out, what do we do? Remember, if the pain is under 4 weeks, we do nothing, especially if they don't have any types of red flags, especially if the physical exam was normal, the ROS was negative. We've ruled out these big three. We can watch for 4 weeks, symptomatic control only. Now, something that I think is going to maybe change the way you do practice, right? Now, it's often said, don't do x-rays, don't do x-rays, don't do x-rays. However, time after time, people do x-rays. So here's something to think about the next time you want to do an x-ray, especially on a female patient. The standard view for doing the LS x-ray here is going to give the exact, or it's going to expose, I should say, the female gonads to the exact same amount of radiation as a chest x-ray done on a daily basis for multiple years. So getting this lumbar sacral x-ray is not without risks as well when we're discussing the female gonads. So something to keep in mind. The reason why we don't want to do x-ray or why we don't want to do imaging is because we don't really see any improved outcomes with early imaging, right? Aside from the exposure that we discussed with the female gonads, the only thing that seems to happen is we have the overuse of more invasive procedures that really are unwarranted to begin with. And the reason is because a lot of abnormalities are going to be seen even in the asymptomatic patient. It's honestly believed that disc herniation are seen in up to 60% of asymptomatic adults, and spinal stenosis is going to be seen in up to 60% of asymptomatic patients over the age of 60. Now, also, the resolution of imaging findings does not correlate with patient outcomes. Let me say that again. Resolution of imaging findings does not correlate with patient outcomes. And some common things or some common findings that really have no clinical significance are going to be annular tears, Schmorl's nodes, and modic changes. So annular tears, these are going to be tears in the annulus fibrosus of the intervertebral disc. Schmorl's nodes are going to represent nucleus pulposus herniation into the adjacent disc. And finally, we have modic changes. This is simply going to be bone marrow and end plate changes adjacent to degenerative lumbar intervertebral discs. So we discussed who doesn't necessarily needs an x-ray. We discussed the red flags, the possible signs and symptoms of cauda equina, cancer, infection. So let's get into a little bit more of the imaging, right? We're really going to have three main imaging modalities here. We're going to have the MRI, the CT scan, and we're going to have the plain x-ray. Now, the best initial test here for a patient who presents with low back pain is going to be the MRI without contrast. CT scan is the next best test when an MRI cannot be performed. And x-rays are generally going to be indicated when we're looking for infection or malignancy. And typically we want to get an AP and a lateral view here. All right, so we can use MRI with contrast for patients who have had spinal surgery in the past because this is going to help differentiate scar tissue from another disc herniation. Now, let's get into some red flags here, right? We have to be cognizant of red flags. And the first thing that we have to keep in mind is age. The older you get, the more likely you are to have serious disease. And the age group that we're looking at here is going to be 50 to 70 years of age. We're also going to be looking for chronic corticosteroid use. We're going to be looking for trauma. We're going to look for, when we do the physical exam, if we notice any type of spinal contusion, that should alarm us. That should be a red flag as well. Do we have a history of cancer, right? These are things that are going to warrant imaging in the patient. Something else that we need to worry about is going to be nocturnal pain. So age 50 to 70, chronic corticosteroid use, nighttime pain, contusion, trauma. Do we have any, in the contusion on the spine, any type of trauma and or history of cancer? These are red flags. Now, we discussed the cauda equina a little bit earlier, but let's recap very quickly, right? Cauda equina is most commonly a result of metastatic tumor, and it's actually going to be the initial presentation of cancer in up to 20% of patients. Other things that can lead to cauda equina are going to be hematoma, abscess, and disc herniation. And apart from the pain, we also want to look for weakness, numbness, paresthesias, and motor deficits not localized to a single unilateral nerve root. Again, bladder and bowel dysfunction is going to be a late finding. Now, the MRI is going to be the imaging modality of choice when we're talking about cauda equina. Infection, remember, this is going to be either osteomyelitis or spinal abscess. And if neurological symptoms are present, order an MRI. Neurological symptoms equals an MRI. If a high level of clinical suspicion exists, but we don't have any neurological abnormalities, get the MRI. Your gestalt is very important. We think there might be infection, get the MRI. The MRI has a 96% sensitivity and 92% specificity when talking about infection. If you have a low level of suspicion, right, you possibly think there could be infection, but the risk factors aren't necessarily there. So we have a low level of suspicion, but no neural abnormalities. Then you can simply start with an X-ray and an ESR. If you have a positive X-ray, then we need to evaluate further depending on the results. If you have an elevated ESR with a negative X-ray, go ahead and get the MRI at that point. Now, X-rays can often be normal when we're discussing infection, especially at the very first onset or very beginning of infection, osteomyelitis. So the X-rays can be normal. It's got about an 80% sensitivity and about a 57% specificity. The ESR, however, the ESR can definitely rule out infection because if we have an ESR that's less than 20, it's very unlikely that we have infection. Things that are going to increase the risk of suspicion here: recent spinal procedure or history of IV drug use, if we have fever, and or if we have any type of localized tenderness. And the last thing that we want to discuss here is going to be cancer. Now, patients who have cancer should have their oncologist consulted. Doesn't matter, breast, prostate, lung, thyroid, kidney. Consult the oncologist, especially with the new onset of back pain. And patients who have a high risk of cancer should have an X-ray plus the ESR. If the patient has a negative X-ray, but we have an elevated ESR, get the MRI. And you're probably asking, what is high risk, right? Who's at high risk for having cancer? The funny thing is, there's really no definition. There's no definition for those patients that are at high risk. There isn't any type of consensus here. However, we're typically looking at age. So the older, right? The older the patient is, the more likely that something bad is going to happen. So we're looking at age. Do they smoke? Do they have a family history of cancer? Rapid weight loss? These are things that might clue us in to possibly having cancer. If the ESR is less than 20 and there's one risk factor or less, then cancer is pretty unlikely, right? We don't need to do any type of imaging. This is for the patient who doesn't have a diagnosed cancer, but we're thinking that they might have an increased risk. We're going to look at these things. We're going to look at the ESR. We're going to look at risk factors here. Now, patients who have a low risk of cancer, they have back pain, and they have no neurological abnormalities are simply going to be treated with observation. And finally, we have compression fracture. Now, risk factors here are going to be glucocorticoid use, age over 70, trauma, osteoporosis, and a noticeable contusion. Now, patients will describe severe and sudden onset of pain with focal tenderness. And if suspicion for a fracture exists, then simply get an X-ray. All right, so now let's get into the treatment and the management of the patient who has low back pain. Remember, the far majority of patients that you're going to encounter have mechanical back pain, have some type of degenerative change. So if we've ruled out these big conditions, we've ruled out cauda equina, we've ruled out cancer, we've ruled out infection with our physical exam by looking at risk factors, by looking at signs and symptoms. If we've done this, then initial management is simply going to be with either NSAIDs alone, or we can add a muscle relaxant if we're thinking that we have muscle spasm as well. The big thing that we want to tell our patients here is that we've ruled out something dangerous. We don't need to do imaging. It's going to do more harm than good. You're going to get better. The majority of patients get better within 4 weeks. NSAIDs will take care of the pain. This way they can function. They have to continue their daily living. No bed rest. Lots of patients want to take time off. They want to lay in bed. They should continue their daily activities. They should not be in bed for more than a couple days. This is only going to worsen the problem. And even physical therapy at the very onset of back pain is simply going to be unnecessary. So it's reassurance, NSAIDs, plus or minus a muscle relaxant. So what do we do with the patient who was treated conservatively but continues to have symptoms? So they come back to your office in 4 weeks and they continue to have back pain. What do? We're going to run through the exact same thing that we just discussed. We're going to ask review of systems. We're going to do a physical exam. We're going to look at risk factors. We're going to ask about medications. If everything is unchanged, the physical exam is the same as prior. The pain is the same as prior, but they continue to have the pain. We don't do anything differently. Imaging at this point has not been shown to improve outcomes. There's no reason to image once again. If the patient still has pain after 4 weeks, we continue to do the same thing. There's absolutely no point in getting an X-ray or an MRI in the patient who is either getting better and or has unchanged symptoms. Now, the caveat here is if the pain has been going on for 12 weeks. At this point, we now have chronic back pain, and at this point, we can start doing imaging with either an X-ray or an MRI. The other thing that we have to keep in mind is that hip pain can often be referred or can often be mistaken for back pain. So if we have hip pain, we have to think of things like avascular necrosis. If we have unilateral hip pain, get a frog leg view. We have to look at the hip as well as possible referred pain. And I'll tell you this, about 80% of the time, you will not have a diagnosis for the back pain. So even if we do an X-ray, even if we do an MRI, the majority of times we will not have a definitive diagnosis for the patient's back pain. So this is the initial workup for the patient presenting with acute low back pain. I hope this was helpful. Remember, the far majority are going to be benign conditions. We don't need to do anything more than NSAIDs, muscle relaxants, and maybe a little bit of rest, but not too much. No bed rest for more than a couple days. They should continue doing their daily activities. Thank you guys so much. If you guys haven't already, please subscribe. If you're watching on YouTube, subscribe to the YouTube channel. If you're hearing this on the podcast, please subscribe to the podcast. Leave a rating, leave a review. It really helps more than you know for the podcast. If you're watching on the YouTube, hit the like button. This also helps tremendously for ranking. Thank you so much, guys. I appreciate it, and I'll see you guys on the next lecture. Take care. Have a great weekend. Bye.